Good morning, and welcome to Your Health Matters. My name is Tracy Trypuc. I would like to share some information. Today is National Wear Red Day. It is a national public awareness campaign urging women and all other people from all walks of life to wear red, to bring attention to the number 1 and number 5 killers of women, heart disease and stroke. By wearing something red, we can bring awareness to reduce risk and to improve health and save women's lives. And now I'd like to welcome my guest. Today, I have with me in the studio Dr. Allison McLarty. She is a cardiothoracic surgeon, associate professor of surgery from the Division of Cardiothoracic Surgery, associate program director, Department of Surgery from Stonybrook Medicine, and co-director, Ventricular Assist Device Program, Stonybrook University Heart Institute. She has also been the speaker of The Venus and Mars of Heart Disease, Why It's Different for Women. Welcome, Allison.
Thank you.
I appreciate you joining me.
Sure.
Thank you. Okay, so you have written extensively in the medical journals and spoken about gender differences. Before we look at individual differences, can you give our viewers an overall picture of what your experiences have shown?
Yes. Over the years, I have seen fairly clearly what is supported in research and the literature, which is that heart disease is definitely a woman's disease as well as a men's disease. About 20 years ago, it was felt to be really just a disease for men. And therefore, most research, most treatment intervention was directed towards men. And then became an awareness that actually it was occurring in women also, but at a later age, because in general, women are protected by estrogen until menopause, and then with the advent of menopause, changes occur in the body, and so the incidence of heart disease in women begins to appear about a decade after in men. But it's not a non-issue, it's very much a real issue in women as in men. And what we will talk about during this time is the fact that the symptoms can be different in women compared to men. The presentation can be different. The actual underlying pathophysiology can be different in women and in men. And that in part explains why for so many years people thought it didn't happen in women, because the classic symptoms that are described in men are not always seen in women.
Right. Okay, thank you. So cardiovascular disease does remain the leading cause of death in women in the United States, and there also lies a disparity among women of color. First, can you explain to our viewers what cardiovascular disease is?
Yes. So it's a disease of the blood vessels, and that is why we see a correlation between heart disease and stroke, for example, because that's all vascular disease. But to speak specifically to cardiovascular disease, it's a disease of the blood vessels that feed the heart muscle. So the heart's a muscle like any other muscle in our body, and it pumps blood around our body. And arteries that supply the heart muscle are like pipes that deliver life-giving blood and oxygen. So when disease occurs within the blood vessels, the arteries can be plugged up, like pipes can be plugged up, and that decreases flow of blood to the heart muscle. The heart muscle can then suffer from lack of oxygen, and one can have a heart attack and have loss of muscle, and then all the consequences one can see. So it's really a disease of the arteries that feeds the heart muscle.
Okay, all right. And so when people hear about cholesterol or atherosclerosis, these are some of the things that you're talking about that can be precipitating factors?
Yes. So cardiovascular disease is essentially atherosclerotic disease. The blockages within the arteries are what we call atherosclerotic plaques, and those are plaques made up of cholesterol deposits with calcium and protein and fibrin that build up over time. If you actually see what a plaque looks like, which we can see at the time of heart surgery, it looks like a congealed pile of old fried egg. That's basically what it looks like. But this builds up within the lumen of the artery, and this is often the culprit that causes the trouble in cardiovascular disease.
Okay, thank you. So 1 in 5 American women has some form of cardiovascular disease. Before we discuss risk factors, can you explain the important differences in how cardiovascular disease manifests in women compared to men, as you were alluding to earlier? Like for women, they experience the symptoms differently than men, and which can then affect their course of treatment, usually.
Yes, that is correct. So, as I said earlier, usually one sees cardiovascular disease occurring later in women compared to men. So that's one important distinction. Not always, it can occur earlier in women as well. And the classic symptoms of cardiovascular disease include things like chest pain, radiating to the jaw or the left arm. That's often what we see on television when somebody's having a heart attack. In women, about 50% of women do not experience these classic symptoms. So instead of the crushing chest pain and the feeling as if an elephant is sitting on your chest, women, for example, might experience abdominal pain or back pain. They might experience shortness of breath or dizziness. They might experience nothing more than an intense fatigue. And so there may be some confusion as to what they're experiencing. It may not be clear that they're having a cardiac event. And I think this is part of the reason that for many years, women with these symptoms, when they went to their doctors, were essentially blown off. And, often it was said, well, you're having a panic attack. I can't tell you in my own practice how often I've seen women eventually come in with a full-blown heart attack, and they've been going to see their doctor for weeks, and they've been given Valium, and they've been given Xanax, and finally they've been told, go home and just relax and stop bothering me, essentially, when really they were experiencing the symptoms of heart disease. So I think a lot of the research and work that was done in the early years that helped people understand what cardiovascular disease is, as you said, was done in men, and so the classic symptoms in men are what everybody thinks about. So it's very important, really, that not just the women, but everybody understands that these atypical symptoms are common and they are real, and they can be the harbinger of a heart attack.
Well, and that goes to, as you were just pointing out, the research, because in some of the literature reviews that I was doing, more of the people who were studied were men than women. And so, that was very surprising. Even some of the later literature or studies that were done, even in the 90s, were of more men than they were of women. And some of the studies also showed that when a woman presented to the doctor, as you were just saying, they were told oftentimes that they were under stress, and so that's why I feel that this is an extremely important subject, because it's not just about awareness for women, but it's an awareness campaign for their families, to be sure that they know what kind of questions to ask their doctor, and awareness for the physicians as well.
Right. I think education for everybody is important. So you're right, a lot of the studies were done in men. Now, gratifyingly, that's changing, and there have been some important studies done that are continuing in women. The Women's Health Initiative study, we'll talk about a little bit, which was an important one, talking about hormone replacement therapy in women and its impact in cardiovascular disease. There is the WISE trial that the NIH is conducting, looking specifically at how ischemia manifests itself in women specifically. And then there are other trials, and there's a lot of effort now going into getting women to be part of the study. So I think researchers anyway certainly understand that it's important to have good representation of women in this field, so that we can understand the differences that are now clearly being seen between men and women. And then, I think Another important thing that's been happening, and the American Heart Association and the NIH have both really spearheaded these educational campaigns. I think what's important is that it allows women and their families also to take some control of their health and their care, and so they can be more partners with their doctors in what's happening in their bodies, which I think is important.
Right. Okay. So now let's discuss the risk factors. I'd like you to explain to our viewers about the non-modifiable, which are risk factors that we cannot change, and the modifiable, which are risk factors that we can change. So if you want to begin with the non-modifiable risk factors.
Okay. So some things obviously we cannot change, and so age is an unrelenting one of them. So everybody's getting older, and age is a risk factor for cardiovascular disease. So the older you get, the more of the accrual of various risk factors that come with age that you experience. And so age is one. And then family history is another. So genetics are strong and true and real. And if one has a family history of early cardiovascular disease, so for example, if your dad had heart disease before the age of 55 or your mom before 65, that is a sign of early heart disease in one's family. And that puts you at a somewhat increased risk. So one cannot change that. So those are risks that are not modifiable. And so, you're stuck with them. Luckily, the modifiable risk factors far exceed the non-modifiable ones. And they're things that we can all change. So I'll just go down some of the big ones, and then maybe we can touch on some of the other ones. So the biggest modifiable one, frankly, is cigarette smoking. So I tell my patients it's like putting a slow bullet to your brain and shooting yourself, because it definitely contributes to mortality for heart disease and cancer and other things as well. So smoking, at the very least, all by itself doubles the risk of heart disease. And with other risk factors, it's an exponential increase. So by stopping smoking, you can help yourself significantly. Other things like high blood pressure, which is fixable with diet and medicines. Diabetes, also fixable with diet, weight loss, medication. Inactivity, physical inactivity, because something as simple as exercise has been shown to decrease your risk of heart disease. Obesity, and everybody knows that obesity is a national epidemic in the United States, and it leads to some of these other risk factors. It leads to hypertension, it leads to diabetes. So obesity is clearly linked to an increased risk. And interestingly, being obese more around your middle as opposed to your thighs is linked to a higher incidence of heart disease. So these are some of the big ones. So we try to target these as we educate our patients. There are others that we are learning more and more about. So stress is a big one. Depression is. So heart disease is twice as common in people who are depressed as not. So depression is. Inflammation is, and that's why there's been so much buzz about things like gingivitis and heart disease, and the molecules C-reactive protein in heart disease, because these are markers of inflammation. And so it's becoming clearer that inflammation is associated with an increased risk of heart disease. So so these are all some of the lesser known but becoming better understood things that are contributory.
Okay. I know there are more we could go into, but for the sake of time. So with regard to risk factors, can you recommend some prevention strategies aside from monitoring and trying to control your blood pressure or losing weight or exercising? Are there some other prevention strategies that you could recommend?
The best way to do it is to think of a lifestyle change. That's really the best way to do it. And the reason it's important is because this business about the development of blockages in the arteries that feed the heart muscle begins in childhood. So if we as adults embrace a lifestyle change and can have it be reflected in our families and our children's lives and behavior and diets, then we help not just ourselves but a whole generation. So, blood pressure control, diabetes, and not smoking are big things. But I mean, diet is more important than people understand. And exercise is more important than people understand. And I think having a healthy diet, making exercise be part of your life, trying to control stress, as best as you can. I mean, I think these things, in addition to partnering with your doctor for taking care of some of the medical things, have a way more powerful impact than people think. I mean, I've talked to patients who say, well, I don't exercise, but how important could that be? I mean, the answer is an hour of exercise a week, even though that's a little bit less than recommended by the American Heart Association, that can significantly decrease your incidence of heart disease. So it may not feel like much to you, but what it's doing in your body is huge.
Yes, it's very important. And you're also establishing a lifestyle that your family can
That's correct.
incorporate. So it's affecting the health in a positive way for your entire family.
That is correct.
Which then can be passed down.
Right, because I mean, our children absorb what they see us doing. It's as simple as that. And our habits will become their habits. So I think we do them a disservice if we stick to all the bad habits that we know lead to a bad outcome in our lives.
Yes. So you mentioned previously about hormone replacement therapy. So with the best medical evidence today, what are the treatment recommendations for HRT? So,
because menopause is linked to an increased incidence of heart disease in women, it used to be thought that a simple fix would be to give hormone replacement therapy and then women would keep being protected from it. And that was a thinking like 2 or 3 decades ago. And then it was studied. And a big study that addressed some of this was Women's Health Initiative. And the results of that study were surprising because what was seen was that in some arms of the study, the incidence of heart disease was increased, not decreased. The incidence of stroke in both arms of the study was increased, not decreased. And then there were some other findings and so on, but those were 2 of the big ones as pertains to cardiovascular disease. And as a result of that, the current FDA recommendation is that hormone replacement therapy should not be taken for prevention of heart disease. There are other reasons people may need to take it, for osteoporosis or other health issues, and so the treatment should be certainly discussed and individualized with your physician. But the important message is that as a preventor of heart disease in women, it's currently not indicated. Now, more studies are underway looking at maybe different timing, different doses, different combos of hormone replacement therapy to see if there are other ways it could be used to make a difference. But currently, we definitely don't recommend it for every woman trying to avoid the development of heart disease.
Okay. So, do you hear from patients that they perceive that there is an improved awareness and response from physicians about heart disease in their own lives, or about, at least with regard to women and heart disease?
I think the tide is turning slowly. So I think there is an improvement. What I think, frankly, has maybe changed even more is that patients are more educated and more aware and are perhaps pushing more to have something done. So, I mean, studies have shown that, even when a woman presents with some of the symptoms of heart disease, the referral for an evaluation is less in women compared to men. The referral to surgery, angioplasty, which are treatment forms for the disease, less for women compared to men. But I find, just speaking to patients, that more women or their families are saying, well, I hear that you don't think I need this test, but I would like this test. And basically, if you don't offer it, then I might seek another doctor and another opinion to see if maybe they have another opinion. So not to say that one should hold one's doctor hostage to to what you want. But I think patients are able to have a more informed discussion with their healthcare providers. And I think, just like patients are being better educated, I think doctors across the board are also understanding that this is a disease for women. The symptoms are different. We need to have a higher radar, and also some of the testing that is done is specifically better in some cases for women. So for example, in stress testing, which is a way of eliciting whether there is coronary artery disease, some of the typical exercise stress tests are better for men than for women. And so adding echocardiography to that, so an echo stress test can give you more information that may be more helpful for women. So in some cases, the testing ordered can be more directed towards diagnosing a woman compared to a man.
Do you feel there's a good network out there? Say, if a woman goes to her family physician, that she's seen for a long time, that he, and then feels that she needs to see a cardiologist, that he would have, and of course you do have to deal with insurance companies as well, but that there's a good network of who are good cardiologists who this patient might be able to see that is aware and knowledgeable of the specific needs of women.
Yes. So the answer to that is definitely yes. I think there is a powerful network out there of good cardiologists who are attuned to the needs of women, and I think primary care physicians also more and more so. And many institutions, Stonybrook included, now have like a women's health center where the focus is on women's health, not just for heart disease, but sort of for everything. So I think people's ears are open and their eyes are open, and everybody is trying to make sure that patients with this important problem are not missed or misdiagnosed. So I think patients can feel more comfortable that when they come to their physician with this concern, that an algorithm of care will be embarked upon that will help them.
That is very important to have that algorithm of care.
I think so, and and pathways and algorithms and sort of an automatic chain of events, that's becoming more and more the norm now. So that if one comes with a particular complaint, then there's a series of tests that are automatic so that less people slip between the cracks.
That's very true. And okay, so we've already talked about women being represented in studies. Is there adequate funding for studies to include women?
So there's not adequate funding for studies, period.
Right, well, yes.
I mean, across the board there isn't, So no, there is not adequate funding for women, for women's studies either. But I think the governing bodies of the funding bodies are sensitive to women's needs and women's studies, and are trying to make sure that they are represented in the funding, in the studies that are funded. But I think, everyone tries to be creative in terms of finding funding for various studies, and so there's partnership with industry and partnership with private corporations and so on. And I think it's critical because, as we saw with the Women's Health Initiative and the hormone trial, sometimes you just don't know until you actually do a prospective randomized trial and see what the data shows. And so I think it's really important that what we think we are learning is validated with the right kind of clinical trials.
Okay. So as we begin to wrap up, what do you see as a need for continuing research and awareness for women and heart disease? And what is your advice for women?
Okay, so one of the interesting areas that is emerging in cardiovascular disease, especially as it pertains to women, is this concept of microvascular coronary disease.
Okay.
The blockages that we've been talking about primarily so far are blockages in the bigger arteries that sit on the surface of the heart. And those are the ones that have been most studied, and those are the ones that are most troublesome in men. There is a growing understanding of what we call microvascular coronary disease, which is where the tiny little arteries that penetrate the heart muscle and deliver the blood and oxygen also can be diseased. And instead of having discrete blockages, the whole length of the little artery is diseased and narrowed. And yet, if you do the studies trying to identify the blockages, it's tough to see them because they're not specific focal blockages. So that's better understood now, and there is a body of research occurring to try to understand better the risk factors for that and treatment for that. And I think it's important because it's seen more often in women compared to men. And I think this particular part of the disease process is one of the reasons why women get misdiagnosed, because they can have the symptoms, but when they go get their studies done, or their cardiac catheterization in particular done, no obvious blockages are seen. And if no further studies are done, then you could just say, well, you don't have coronary artery disease. This is not your problem. But specific testing can be done on the microvasculature. Medicines can be dripped in at the time of the study to show reactivity of these arteries. And that can be used as a diagnostic tool, and then therapies can be begun. So I think that is a fertile area for research. And again, because women more often than men experience it, I think it could be of great benefit to women.
Okay, thank you. Any final thoughts?
You know, I think knowledge is power. So I think something like this is very helpful, because then it makes one think and reflect and question, and then self-educate, and then begin to take control. And I think it's really important for patients to consider themselves partners in their healthcare with their physicians. So I would encourage patients to learn more about heart disease in women, and to be somewhat reassured that doctors and physicians across the board also are understanding this better and embracing women's health more.
Okay. Well, I thank you very much for being here today.
Thank you for having me.
Okay. This has been Dr. Allison McLarty from Stonybrook Medicine, a cardiothoracic surgeon, Associate Professor of Surgery, Division of Cardiothoracic Surgery, Associate Program Director, Department of Surgery, Stonybrook Medicine, and Co-Director, Ventricular Assist Device Program at Stonybrook University Heart Institute, and speaker of the Venus and Mars of Heart Disease, Why It's Different for Women. I thank my guests very much for all of this important information today. Thank you, Allison. Please tune in next week for another Your Health Matters with Tracy Trypuc. Have a safe and healthy day.